In IVF, ovarian stimulation medications are widely applied. After the medication, in some patients, a decent number of eggs are retrieved. However, in other patients, only one or a few eggs are retrieved. What causes the difference? Hello everyone, this is Dr. Z Tao Liu. I'm an American board certified obstetrician and gynecologist specializing in infertility treatment. Today, I'm going to talk about ovarian stimulation medications and their mechanism. In a normal lady, pituitary in her brain release gonadotropin, including FSH and LH, to help the follicle to development. FSH and LH have similar structure. Both of them have two subunits, including alpha chain and beta chain. FSH can help the follicle grow bigger. LH can help the follicle finish the last step of maturity and ovulate. The mechanism of ovarian stimulation medication is to elevate blood FSH level and then induce the development of multiple mature ovarian follicles. There are two groups of ovarian stimulation medications. They are gonadotropin analog and gonadotropin release stimulant. Gonadotropin analog are a group of medication which has similar structure or identical structure to FSH. Both follicle and GNRF are synthetic proteins created by bioengineered technology. Follicle has both alpha and beta chain of FSH. GNRF have only beta chain of FSH. Manopure is a human urine extract. It has both FSH and LH activity achieved by HCG supplement. All these gonadotropin analogs act directly on follicle. Gonadotropin release stimulants are medications which stimulate pituitary to release FSH. For example, clomiphene is a selective estrogen receptor modulator. It acts on hypothalamus, possible pituitary to release FSH and LH. Letrozole is an aromatase inhibitor. It can inhibit peripheral tissue to produce estrogen and cause negative feedback to produce more FSH and LH. Before we explore the effect of ovarian stimulation medication on follicle, let's review the follicle development and maturity in the ovary. All the follicles are formed when a lady is still in her mom's uterus. After she is born, no new follicle is formed. But all the follicles are in rest status. After a while, a group of follicles wake up. They grow bigger and develop into primordial, primary, secondary, and andro follicle at the size of 2 to 5 millimeter. This step is called initial recruitment. It takes about more than 1 year. This step is gonadotropin independent but sensitive. It means follicles still can grow into andro follicle stage. However, a fewer follicle can grow into this stage if FSH or gonadotropin level is low. Andro follicle count is a marker of ovarian reserve. If ovarian reserve is high, andro follicle count will be high. If ovarian reserve is low, andro follicle count will be low. When the follicle reach andro follicle stage and under the effect of FSH, the follicles are growing bigger. However, only one follicle can grow bigger and bigger and reach a mature size. And the effect of LH, the follicle will finish maturity and ovulate. The rest of the follicles are going to shrink and absorbed by the ovary. The development of the follicle from embryo follicle to graphene or mature follicle is called cyclic recruitment. This step is gonadotropin dependent. The follicle cannot grow bigger without gonadotropin. In a natural cycle without medication, only one follicle can grow bigger and ovulate. In IVF, ovarian stimulation medication can elevate FSH level, and it can cause a higher percentage of follicle grow bigger and a lower percentage of follicle shrink. As a result, more follicles or more eggs can be retrieved. Now we can see ovarian stimulation medication will not increase the embryo follicle count. They might cause a higher percentage of follicles grow bigger. In IVF, blood FSH has two sources. It can either from endogenous natural release of FSH and LH from pituitary, or from medication or medication stimulation. Now let's review 3 cases to explore the effect of ovarian stimulation on the patient in IVF. And all the 3 patients were evaluated between day 2 and day 4 in her cycle by ultrasound and blood work. Patient ZL is 39 years old. Her embryo follicle count is only 3, and her FSH is 12.6. For this patient, we know her ovarian reserve is low due to low embryo follicle count and high FSH. And we know for a lady at 39 years old, her embryo follicle count should be between 11 and 12. And for this patient, after we gave her ovarian stimulation, we only get 1 egg. And the patient LB is at 41 years old. Her embryo follicle count is 8, and FSH level is 12.4. And we know that she has a normal ovarian reserve at 41 years old. After ovarian stimulation, we get 7 eggs. Patient YG is at 39 years old. Her embryo follicle count is 16. Her FSH level is 6.4. She has a higher ovarian reserve. As a result, after stimulation, we get 11 eggs. From these 3 cases, we can see the higher the ovarian reserve, the more eggs we retrieved. The total retrieved egg number cannot be higher than embryo follicle count. The above information represent my personal opinion. They are for medical education to the public. If you have any specific medical question, please get medical advice from your physician. I hope you would like this video. Please give me a thumb up and leave your comments or share it with your friends. If you want to review more education videos from me, please subscribe my YouTube channel. Thank you.